Well, thanks for having me. My success with IPL, people think it's an overnight success. This is actually 20 years, so I tell people this is 20 years in the making. We just got FDA approval for IPL specifically for dry eye. My talks with the FDA started about 7 years ago, and the first time we met was, well, are you hurting anybody? And then little by little, they wanted to know the effectiveness of IPL. So this is me giving IPL to an optometrist. Essentially, what we're trying to treat is meibomian gland dysfunction. So this is what you're going to see, and I tell people of all these little things here to look. When I first started ophthalmology, the first thing I would do is look at the eye. Now that I've been doing IPL for 20 years, the first thing I look at is people's face. Then I start looking at their lids. Then I start pushing on the glands. And then finally, I will get to their eyes. So you can tell a lot when a patient comes in. So let's just take this slide here. And if it was a little bit darker, you could see. But look here. You have, first thing is this patient is exhibiting meibum that is more like toothpaste. Then you can also see that they have these abnormal telangiectasias that are going to the meibomian glands. And now we know that these little abnormal blood vessels actually secrete inflammatory mediators that actually break down the skin and actually can break down the gland. Then you look here and you start seeing that a patient starts to lose eyelashes when they don't have normal meibum. And you can also see that all of a sudden you start to see signs of Demodex and bacterial overgrowth. So you have scurf, you could see collarettes. One thing that we started to measure is what is the distance between where the meibomian glands are and the eyelashes. So what you'll start to see in somebody that has meibomian gland dysfunction is this little area will start to thicken, and the area where the eyelashes go towards the meibomian glands is much further. So this is something that I actually look at and measure. Then I start looking at the conjunctiva, and I see that here you see some inflammation of the conjunctiva, and then you see the angry blood vessels there. So how did this start? So what I did is I had a clinic that had 3 pods. In one pod we had ophthalmology, in another pod I did LASIK, and then I had this empty pod that was sitting right here. And I started doing Botox for wrinkles. And then the patients that would come in and say, can you do anything else? So I started doing fractional CO2 laser. And then the next thing I bought was an IPL system. What I tell people is, you could have all sorts of IPL systems. There's hundreds of IPL systems. But essentially, there's first generation IPL systems. And then what you'll see is that IPL systems have actually evolved over time. The first generation IPL systems, all they did was give you one big flash of light. So what we would have to do is measure what the skin would look like when we treated them with this little area right here at the trachea. If it was too red, then we knew the energy was too high. If it wasn't red at all, then we knew we weren't getting an effect, and that's how we would pick energy levels. And the problem with first generation IPL systems is what happens is the more you use it, the less output that IPL system will give you. So one day I would do IPL, then I'd go, okay, this patient gets 16 joules. Then I would do 3 or 4 months of IPL, and that patient would come back. And then I'd have to, and I've been using the IPL for 3 or 4 months, I'd have to titrate the energy on that IPL. So if you look at my charts 20 years ago, a patient could have 13 joules, 26 joules, 18 joules. It was all over the place because those bulbs would wear out. So what you're seeing as IPL evolves is that like a system like the Luminous, is that the actually bulb will give you 1,000 shots and it'll be consistent energy every time you use it. So I had a hard time getting people to believe me. The first time that I gave a talk, first of all, I said I was going to give a dry eye talk and maybe 5 people showed up. Then I said that we were doing IPL for dry eye and people are like, what? What are you talking about? Light to treat dry eye. But finally, Ascaris actually published one of my case studies. So this is the case study that got published. I turned this in 2003 after I'd been doing IPL for a while. And then Ascaris gave me a grant to look at this, and I presented it at Ascaris, and still, really, people didn't believe me that this was actually a treatment for dry eye. So how did it all start? What happened is I started treating patients in my aesthetics clinic for rosacea. And IPL back then, even in those first generation IPL systems, what you could see is that the IPL was really good at closing down blood vessels. So patients would come back and they'd have bad rosacea. We would treat them with IPL, and then their face would clear up. And then I had 1 or 2 patients that said, you know, doctor, my skin is better, but actually my dry eye is better. So then I started looking at their lid margins, I looked at their tear film, and I said, you know what, you're right, your tear film does look better, and that's how we started this whole thing. So I actually did IPL for dry eye on patients for 7 years without charging them, just trying to learn what energy levels I could use, how often they could be treated, what pulses can be done. So it was a very long and tedious road to getting to where we are now. So I don't think I have to go this. I think all of you know, basically meibomian gland dysfunction is the most common dry eye that you're going to see. You got about 20 or 30 meibomian glands in each lid margin. I actually look at each meibomian gland, especially when I do expression, to try to see what that gland is producing. It's the fatty layer of the tear. If you don't have a normal fatty layer, your tear evaporates too quickly, and that's why we look at tear breakup time. So actually, rosacea was the perfect group for me to discover this in. The reason being is 80% of rosacea patients have dry eye disease. So now I was talking about how I look at patients. If I see a patient come in and they look like they have rosacea, I'm already starting to talk to them about dry eye because I can look at their glands, and their glands are dysfunctioning, their blood vessels, you can see those telangiectasias. And usually the eye doctor is going to be the first one to diagnose rosacea on these patients. The reason being is that dermatologists, when they're looking at the patients, they're just looking here at the skin. They really don't have the advantage that we have by taking a microscope and looking at the thinnest skin of the face. So a lot of times I tell patients, you have rosacea, and they go, I don't have rosacea. And I go, you do. And what happens as you get older, your epidermis thins, and then you start to see those blood vessels on the face. But you could be the first one that diagnoses rosacea on these patients. What's interesting is now we have years of experience in rosacea, and we realize that on the skin, these patients are expressing a lot of inflammatory cytokines on that skin. Same thing with the telangiectasias, they're expressing a lot of cytokines. The one that's most interesting that I want you to concentrate on, I've been working with a group out of Singapore, and we were trying to figure out what is the most specific inflammatory cytokine in a dry eye patient. And it turns out to be interleukin-17. So where does interleukin-17 come from? It comes from T cells to T helper cells to interleukin-17. Now, why is that important? For the last 20 years, we've been researching, and our clinic is involved in all these research. We've been trying to find drops that actually help patients with dry eye. And we have 2 categories, all the drops that have failed and the drops that have been successful. Look at the drops that have been successful. You have Restasis, or let's say cyclosporin. Why is cyclosporin helpful? Because it lowers the T cells. Lower T cells, you lower interleukin-17. Then we had lifitegrast, which was approved. I don't know if it's here yet. But what does lifitegrast do? Again, another T cell modulator. So what you're going to find is the drops that work and the medications that work have a connection to decreasing interleukin-17. And it turns out that not only, in the dermatology world, they found that intense pulse light decreases interleukin-17 on the skin. And then if you read our paper in American Journal of Ophthalmology, we showed that actually intense pulse light will decrease the amount of interleukin-17 on the tear film. So what are the 2 specific markers for dry eye? Interleukin-17 and interleukin-6. And then when you talk about prostaglandins, yeah, maybe they have an effect on dry eye, but not so much as interleukin-17 and interleukin-6. And why do we know that? In practice, you give patients a steroid drop, that doesn't control their dry eye. You have to do something to control their T cells. All right, so what is IPL? So IPL isn't a laser, it's actually a flash lamp. And it's made in xenon gas. And why is xenon gas important? Go back to your chemistry, it's a stable gas. What happens when we do IPL is we actually throw electricity into this stable gas. That causes instability for a brief second in that stable gas, but it's stable, so it wants to go back to stability. When it gets back to stability, that releases wavelengths of light. And that light is in a broad band from 400 nanometers all the way up to about 800 or 900 nanometers. What I've found in my research, and we'll get into LLT and all this other stuff, is what is the important wavelengths in terms of getting meibomian glands to work better? It's in the red range. So 600 nanometers to 700 nanometers works really well in intense pulse light to stimulate meibomian glands to work better. So with intense pulse light, what we're doing is we're putting a special filter so that we can get this red over here to the meibomian glands. And then as IPL has evolved, we realized this is the thinnest skin of the face. If you gave them all of the energy all at once, you would burn this. So the hardest thing to do over the years was figure out how do we get closer and closer to the lid margin so this energy can get to the meibomian glands. And what we found is if you treat a patient here, you might get some effect. You treat a patient here, you get about 25% effect. You treat a patient here, you get 50% effect. But if you go to the lid margin, now we're getting 97% effectiveness when we're treating these patients with IPL because we're getting that red light specifically to the meibomian glands. So over the years, we're learning what is the mechanism of action. So the first mechanism of action that I saw with IPL is that it actually, these wavelengths of light will penetrate the epidermis, go into the dermal layer, and actually recognize oxyhemoglobin here in the blood vessels of the telangiectasias. So it does thermal coagulation of these telangiectasias. The other thing that we know about red is when you're doing IPL, it will recognize melanin in the melanosomes. So that's why in the beginning, and I'm going to tell you how we've gotten around this, in the beginning, the patients that we were treating were Fitzpatrick type 1 and Fitzpatrick type 2. But now that this technology has evolved and we can change the pulses, change the energy levels, change thermal relaxation, we're able to do patients who have Fitzpatrick type 5 and Fitzpatrick type 6. So when this light gets absorbed and causes thermal coagulation here, that generates heat. So when it generates heat in the dermis, the other thing that we discovered is it actually opens up the glands and it melts the toothpaste-like secretions, so we can actually do expression of the glands and get that meibum, that abnormal meibum out of those glands. But as you can see, if you have dark skin and dark pigments that is absorbing this energy, that's going to generate heat as well. So if I have a Fitzpatrick type 1 and I give them energy, let's say I just give them a little bit of energy, they're not going to feel as much. If I gave that same energy to somebody who's darker, they're going to feel that energy more because their dark skin is going to actually absorb that energy. So that's why in the beginning, if you try to do me with a first generation IPL system, I'd be like, oh my gosh, this is painful. This is so painful. And IPL does not have to be painful to work. And that's another thing that I've learned is that you can get away with lower energies and you don't need higher energies to work. It's kind of like ultrasound. When you're doing ultrasound, if you can take care of a cataract with minimal ultrasound, then do that because it's going to be better for the patient. Same thing here. You want the minimal amount of energy that's going to stimulate the glands to work better. You don't have to give them more energy. So more is not always better. And then over the years, we've learned that there's more mechanisms of action. So this was really big in COVID. So one of the ways that hospitals were trying to take care of COVID is they had this IPL machine. So it's called Xenex. You know, we said it's xenon gas. So you take this machine, you put it in a room, you close the door, and it flashes IPL all over the place, which kills all microorganisms. So when we're doing IPL here at the lid margin, not only are we killing overgrowth of bacteria, but we're actually killing Demodex as well. And so I've been doing studies with a group out of China who's been able to keep Demodex alive for at least 24 hours in a special solution. Demodex love to be by the hair follicles. They love to eat dead skin, and this is what we look at. And so essentially, when we give IPL, we can show after a shot of one IPL shot that we can actually kill these Demodex in their tract. What's very interesting about Demodex is each one of these Demodex has 6 eggs in it, so that they can multiply very quickly. So this is why Demodex is such a problem. If you have just a few Demodex within a couple of days that are uncontrolled, they will release their eggs, and now you have 30 Demodex, and then you have 60, and then you have 90. All right, so what is the number one reason why I believe that IPL works? And it's this whole process of photobiomodulation. So essentially, photobiomodulation is wavelengths of light that actually stimulate the mitochondria to work better. And we've seen this in the aesthetics world using red light to stimulate fibroblasts to make collagen and elastin. We've seen this with blue light in terms of taking care of acne. We've seen this in orthopedics where they use infrared light to help people heal quicker after muscle surgery and after bone surgery. And this is what we're doing. We're actually using IPL to stimulate the mitochondria. So actually, let me go back. So even in retina, now the retina world is getting into using light to stimulate cells to work better. They're actually using infrared light on AMD patients, age-related macular degeneration patients, to help those patients' cells work better. So that's what we're doing here, is we're using IPL to stimulate the meibomian glands to work better. And this is important because we need something that's actually going to make the meibomian glands work better, because we have plenty of patients that come in and they've got meibomian gland dropout. The reason why I'm showing you this picture specifically for meibomian gland dysfunction and meibography, this is a patient that actually had probing. And one of the reasons I have a problem with probing, if you do meibography, what you're going to see is you have patients that have all sorts of weird meibography, that the gland doesn't go straight down, the gland goes like this, or can go like this, or curly. And then all of a sudden you do probing, what happens is you can transect the gland. These little dots are actually blood clots in a patient that just had meibomian gland probing. So basically the probe went in and it cut off the gland. So if you were to probe this gland, you would actually transect the gland. And this is a big problem because we have a lot more doctors that are trying probing for the first time and they're actually transecting glands. So if you're a prober, I would do meibography first and make sure that those glands aren't going in a weird direction. And then I said we generate heat. Basically, if you do IPL, you can generate and get up to, in the dermis, 53 degrees Celsius. What you need is at least 43 degrees Celsius to actually melt these toothpaste-like secretions. So this is me on a patient who's severe and I'm doing expression. I always tell people about the physics of expression. So if you have lipoflow, how is lipoflow expressing the gland? It's squeezing and releasing, squeezing and releasing. But the physics of, it's non-Newtonian physics, what you want to do to getting toothpaste out of a malleable vessel, so just like getting toothpaste out of your toothpaste holder, you want to apply direct pressure for a period of time, because actually shear stress will decrease the viscosity of thick meibum, so that over time, if you just sit there and hold, more and more and more and more meibum will go. So when I do expression, I will just sit there for seconds and just keep expressing, because shear force will actually decrease viscosity and you'll get more out. And then what you'll see is over time of giving IPL treatments, the secretions will become less and less thick, viscosity, so they'll go from a toothpaste-like secretion to a butter-like secretion, and then finally it'll go to an olive oil-like secretion. So this isn't a one-and-done treatment. It usually takes 4 treatments. And then this is a typical patient. You see the telangiectasia. You see this is a young patient, actually 33. You see a loss of eyelashes. You can see those telangiectasia. She never knew she had rosacea. You could see the thickening of the lid margin that I was talking about. Here's the gland, here's this. You press on the gland, nothing comes out. And then this is her after 2 IPL treatments. Why is this important? Young cells react much quicker to IPL than old cells. So if I have an 80-year-old that comes in, has never been treated for meibomian gland dysfunction, and they're coming in for IPL, they may need more than 4 treatments of IPL to get their glands working. If I have a young patient, a 20-year-old, and they're just starting to have mild meibomian gland dysfunction, it may only take 2 or 3 treatments to get them going. So remember, and this makes sense. Younger cells react quicker to treatment. All right, so these are all the reasons why IPL works for dry eye. So it kills bacteria, heat and expression, and we'll talk about in the FDA study what heat and expression does and why we should do expression, photobiomodulation, and one more that you're going to hear about more in the future is heat shock proteins, HSP. So what it turns out, whether you're doing a CO2 laser or you're doing IPL, anything that generates heat but doesn't kill a cell will actually cause the DNA of that cell to produce heat shock proteins, and those proteins will protect the cell and actually makes the cell work better. So there's plenty of studies, and this will win a Nobel Prize, I believe, one day, is that HSP, and this is only one of the heat shock proteins, but it's the one that's most studied, that we're going to find that heat shock proteins, if we can stimulate the body to make them, it will cause better regeneration of cells and improvement in DNA in terms of replication. And so the good thing about IPL, it's been studied to show that it stimulates heat shock proteins. So there's been plenty of papers of IPL and improving dry eye disease, but what the FDA wanted was a true control group comparing IPL with expression to a sham treatment. So this is what we gave them. So there was 3 centers that participated, our clinic, Dr. Dell's clinic in Texas, and Dr. Neil Desai. So I want to give them credit for helping in this project. We used my parameters and protocols. So we did one patient, and we divided up the patients. One patient would get IPL with expression, and another patient would get a sham flash, and then get expression. And they had 4 treatments, and we did a Fitzpatrick 1 to 4. We showed that we showed clinically significant improvement in tear breakup time with IPL with expression as opposed to sham with expression. But expressing glands actually will improve meibomian gland dysfunction and tear breakup time. So that's one thing that we learned in the study. And then OSDI, so you know any OSDI above 33 is severe dry eye disease. So most of these patients in this study had severe dry eye disease when you looked at OSDI, and we had significant clinical decrease in OSDI in the meibomian gland IPL with meibomian gland expression. So this is actually the first time that this data, I'm presenting this data to you. And then this is where we get into dropped out glands. Can we bring back meibomian glands that are no longer functioning? And this, one of the things that we did in our study was looked at glands that were dropped out and could we bring them back to functioning? And this is where we really beat just a sham light treatment, that we actually showed improvement in glands and improvement in bringing back glands and bringing back the expressibility of those glands. So you can bring back dormant glands with an IPL treatment. So we had to explain why these patients that just got expression showed improvement in these things, and there's plenty of studies that show that if you express your patients and express their glands, they're actually going to feel symptomatic relief and their tear breakup time will improve. So people ask me all the time, do I express after every IPL? I express after every IPL. And when you look at what I do with low-level light treatment, it's the same thing. I do expressions after any kind of light treatment. So this is actually 13 years of work. So low-level light treatment isn't something that just came about this year. I fought for this patent very hard because, again, the patent office didn't understand it. But I finally got a patent on low-level light treatment. So low-level light treatment is completely different than IPL. So IPL will give you energies up to 10 to 30 joules. The energy level that we're getting with low-level light treatment is LED light. So it's not xenon flash lamp, it's LED light, and it'll give you about 1 to 3 joules. So the 13 years of experimentation, I tried all different LEDs and energies with LEDs. So they're very specific. So IPL, we're dealing with broadband light. With LEDs, you're getting a specific light. So it's either going to be like a 410 or a 413 or a 610 or a 630 or infrared at 830, 890. And I tried all of these to figure out which are going to be the light treatments that actually can help patients and help their meibomian glands. So this actually is the first LLT that I made, and I made this in my garage. I just took something, got some LEDs, and just made this and started treating patients just like I did with IPL. And then I made this. This is, it has 3 different types of LEDs in it. It has blue light, it has infrared, and that's the one that you don't see, and then it had red light. And what I could do is I wanted to see could I combine infrared with red, or can I combine red with blue, or can I do just blue alone? And then I just went through the process of elimination to see what would work. So one of the things that is very interesting is that, so masks are used in aesthetics. The reason why masks are used in aesthetics is they're trying to get the epidermis to produce fibroblasts and collagen. Masks for meibomian gland dysfunction, we tried them. We tried them years ago because there were already masks available for aesthetics, so I put masks on patients. The problem is that energy level does not penetrate down to the dermis where the meibomian glands are. So the only thing that you get when you put a mask on somebody, it's like a warm compress because that heat is transferred over to the epidermis and it doesn't penetrate down to the dermis. So if you want to use a mask on a patient, it's like better than a warm compress, but it's really not penetrating down to the dermis where the meibomian glands are. You actually have to put this low-level light there. Then the other question I get is, if I have somebody with severe meibomian gland dysfunction, are they going to be treated with low-level light? And no, they're not. They're not going to get better. So how we use low-level light is that if I have a patient with severe or moderate meibomian gland dysfunction, I hit them with IPL, I get their meibomian glands working again, and then I give them a home light treatment for them to use. So that's the one good thing about LED. It's safe to use without causing any damage to the eye, whereas IPL can cause damage to the eye. So I know I've thrown out a lot of information. I always keep my phone and make sure that I don't go over time, and I'm always proud of myself when I don't. Because if you give me a microphone, I can talk all day about this stuff. But if we opened a clinic in New York, and we did it for a couple reasons. We're actually in Tennessee. But we opened up a clinic in New York to train doctors, and then we had so many patients that were coming to us from the East Coast. So if you ever want to come to New York and watch us treat patients, we do it on a Saturday, so you can fly in on a Friday night. We treat patients all day with IPL, and then you can go back home. We have our own meeting in Nashville twice a year. With COVID, that's kind of changed. But if you ever want to come to our meeting, it's called the TAD Conference in Nashville, Tennessee. You can come and see it. It's usually in October and February.
Thank you very much, Rolando.